I have to say, Kerry, that was an amazing presentation in terms of both the content, but also your ability to handle the challenge of the technologies. I was going to just make it clear at the beginning how much we're very grateful for all the hard work you've put into getting the OPC audit programs up and running, with you being a big test bed for everything we've been doing and inputting into all the thinking. So without you, we wouldn't be here. So it's been a massive input. So I wanted to thank you for that too. So when you don't like the rules, of course, guys, that come out of this, you blame Kerry or Joe or Russell, all the people that sit on our steering committees. So and Cynthia is also joining us now, and Cynthia's also been absolutely pivotal in our audit program and our collaboration and active collaboration with the Woolcocks. So Cynthia, I was going to just get you to come in here and give some reflections on what Kerry was talking about in terms of treatment, but also to particularly think about inhaler technique in COPD. And we're going to get some thoughts later from Omar, but just to get your sort of take on this, because you're probably the world's leading expert on inhaler technique.
Well, I guess there's several things here, and I guess with inhaler technique, like with so many other parts of medicine, it's also about the history of inhaler use. So, I mean, what inhaler is selected for them to start off with? Are they well, or are they having symptoms when that inhaler is actually being prescribed? What's going to happen as the disease progresses? Are they still going to be able to use that inhaler? Who's shown them how to use that inhaler? Who's then following up how that inhaler is used? Because we can teach patients how to use inhalers, and we know that really almost 100% of patients can be taught how to use any one inhaler on a good day. But whether they continue to use that inhaler correctly, and sometimes it does require practice. They do need to practice how they're supposed to inhale through that inhaler. What happens when they're sick? What happens when they go into hospital and the hospital formularies will have a particular inhaler that they use? The patient won't have a choice what that inhaler is, and they're going to leave the hospital with that inhaler. What happens when they come home? Do they continue with that inhaler when their lung function might be compromised? Are they going to go back to their other inhaler? I mean, they're all important things, and I mean, I think we although we don't have the direct evidence of lung function and peak inspiratory flow and the device, I mean, there are some links there to say that when people are not well, some of them potentially are not actually going to be able to inhale properly through their inhaler. So, I mean, in some ways, I don't think we have a health system that ensures that they necessarily go and see their doctor straight away or go and see their pharmacist straight away to get that support. So we have to be, I think, aware of that.
Thank you. Okay, so I've got some interesting clinical questions been building up here. So, Kerry, you said Prevnar and not Pneumovax. Why?
Okay, that just came out this week. I mean, I don't know the evidence around it, but it's been talked about for a while now that Prevnar for that first vaccination is going to be more effective than the Pneumovax, the pneumococcal, the 23 valent one. And so it was rushed upon us this week, bit of a sudden. We knew it was coming, but we didn't think it was at the moment. So the first dose is Prevnar, and then the subsequent booster doses are Pneumovax.
Okay.
So presumably because it's been shown to be Prevnar is a bit more effective, which is what we're using in the children as well.
So is that in the immunisation guidelines, Kerry, or is it have to be private?
Yep. No. That's as of the 1st of June, as of last week. It's in the it's on the National Immunisation Program from the 1st of July. It was just announced, as I said, on Tuesday or Wednesday. And but the interesting thing is that some of the other risk groups, such as diabetes and smokers and heart disease patients, have actually been taken off the funded schedule, which I was a bit surprised at.
Right. And so there's a lot of other questions coming in on Prevnar. Is it just for COPD in the older patients?
No, so it's for 70 years old. So at the moment, we are doing pneumococcal vaccination from 65 onwards, and then the at-risk people have a second dose 5 years later, and then 5 years later again. But for the on the age criteria, it's from 70 years of age. So as of the 1st of July, they will all be offered Prevnar instead of Pneumovax. Then the patients who are deemed to be high risk, such as our patients with COPD, then they can have it at diagnosis, and they'll have Prevnar diagnosis. But we used to also, and that's through the national program funded, but we also used to be able to, it will change from the 1st of July, be able to do the patients with diabetes and heart disease, but they will no longer get funded vaccine.
Just a comment to people. I notice there's a lot of questions coming in on the Zoom webinar chat. We're not looking at those, so you need to put them on the Q&A if you want to get an answer. There is a higher risk of glaucoma, apparently, in regular users of ICS and LABA. Well, let's answer that first of all. Is that true?
Well, certainly we know that patients who have been exposed to high-dose ICS, the asthma patients were shown to have higher glaucoma and cataract disease. So I'm not quite sure whether your observational data, David, has shown anything.
Yeah, we haven't picked up much, to be honest. I mean, I'm certainly not worried about the LABA at all. And, you know, I think the ICS, unless you're using nebulized, you're generally not getting much in your eyes. And as long as you're on a low dose, you know, I don't think we've picked anything up. But I don't think I've actually, I'm trying to remember how much I've looked at, but I don't think I have. So maybe I need to go back and do some more looking at that. But I think the clinically important thing is if a patient needs ICS, then we should be given ICS. If they need a LABA, they should be given LABA. And if you're worried, you can always do, anyone's got a higher risk of glaucoma, obviously ophthalmic checks are required anyway. I don't know what the reimbursement situation is on that in Australia. But I'm sure Kerry or Russell or Cynthia will know the answer on that one.
I mean, patients can, certainly optometrists do get Medicare rebates, so people can get their glaucoma checks at optometrists funded under Medicare.
Right. Gosh, there's a whole debate gone on about Prevnar. Sorry, I'm going to have to pass on that. There must be, I think there's at least 30 questions there.
People could, if they, I think there was something that came through the college last about the changes in immunisation.
Right. Okay. You're breaking up, Kerry. We might have to pass on that answer. Okay, I've been told by someone to talk about the POROS study. The POROS study was one of our studies that I'd forgotten about at this point in time. But how inspiratory muscle strength and function is compromised following an exacerbation. So what are the implications of that poor inspiratory effort around around exacerbations? I'm going to throw that at you, Cynthia. You know, what are the implications for that? I mean, does that? I'm going to mix in another question that I've got here, which is about using spacers. So, should we be using spacers in such patients with, you know, either MDIs or SMIs, or should we just be teaching people, making sure they do enough for their particular dry powder inhaler?
Yeah. Well, I mean, the inspiratory flow is going to be important, certainly for the dry powder inhalers in particular, where we know that the optimal dose is released at that first inspiration. So patients do have to generate a sufficient inspiratory flow to get a dose of a dry powder inhaler. So, I mean, if there's any real concern or doubt, well then a metered dose inhaler with the spacer would be the one that you think is least risk. But definitely that inspiratory flow and the implications that has for medication use is very important, and it should be assessed. It should be looked at. You should know what's going on there. But it's not something that's measured very often.
No, and I think one of the things that we found in the Critical study, and Omar will be talking about it soon, is actually nurse or pharmacist observed inspiratory maneuvers was pretty good at finding those who had poor control related to their dry powder inhalers. So, you know, it was actually as good as some of that. We actually did some really clever tech with inspiratory cycles of vitalograph spirometers with the inhalers on the end. The tech all broke down and didn't give us the answer. And actually and right now tech can't be used because of COVID. So right now, actually watching inhaler technique and checking for adequate inspiratory effort is probably still not bad. I don't know what you think.
Yeah, absolutely. And actually showing a patient what their inspiratory maneuver is when they're using an inhaler actually is helpful in them then going away and using it better, and then recognizing when it's not right as well.
Yeah. Okay. I'm going to have to draw things to a close for our coffee break. We're going to give you. Oh no, I'm reading this wrong. We've got another 10 minutes. I've got to. It says call Omar. Well, Omar appeared on our screen. I've got 5 more minutes. Okay. So I can bombard you with some more questions. Gosh, pneumococcal. Kerry, you said we should start llama first generally. Why? Why not do a llama first?
Well, certainly the evidence seems to be around the llamas and reducing. I mean, years ago, ages ago, they showed that.
Oh dear. Kerry, you're breaking up. Russell, step in.
Okay, well, I think llamas first. It's pretty universally agreed that they have much better anti-exacerbation data.
Yeah, and that's exactly right. The llama data is certainly better on exacerbations, and that's been shown. I mean, llamas are probably that bit better, maybe a little bit better on some of the symptom side, and of course, that's why they make a great combination together. You know, and that actually makes sense. Someone's asked me, why on earth, Russell, you and I and a lot of the audience agreed on stepping that triple therapy patient down earlier to LAMA. Who'd had a couple of pneumonias, but no other exacerbations. So why on earth were we taking that risk?
Well, look, when this topic first came up, I started to put a slide into my talk saying, you know, we don't need more wisdom trials. We need a little bit more wisdom in our prescribing. In other words, how on earth did the majority of these people get to high-dose ICS SLAVAs in the first place when there was really no indication? So we don't need more wisdom. We need a bit more wisdom ourselves. And if they're inappropriately on a high-dose ICS, I see no dramas in getting them onto a LABA as the option, providing we've looked at their exacerbation history and provided we've looked at their eosinophils and their actual, you got to try and do a little phenotyping in your practice to see the most appropriate ones. There's obviously patients who I don't step back, but wherever possible, I am trying to get them to more correct therapy in this day and age. And
on the other side of that coin, we need to make sure that the right patients get them as well. Get them enhanced too. So I've got some interesting questions here. You mentioned theophylline earlier. Where does it fit in? It doesn't. Theophylline at high dose is a bit of a mild bronchodilator, but it also has a lot of side effects at high dose. So people have played with it at low dose. And there was a big debate as to whether it had any effects. And there's a guy from the UK called Peter Barnes was very provocative and suggested it overcame it by adding low dose theophylline. You overcame steroid resistance in COPD, and steroids would suddenly work. Well, We did that. We did the randomized trial, 1,400 patients with COPD over a year. We gave them theophylline or placebo, published in JAMA last year. It did nothing. The rate ratio was 1.01 for the exacerbations. So absolutely useless. No role whatsoever. I've never got a result as clear cut as that in a clinical trial ever. So that, and I think that's probably enough for now. We're going to break for coffee.